The stories of Kenyans who are unable to clear their medical bills after receiving treatment have become all too common.
I came here on 25th December. I had been told I will deliver on the 26th. I was taken to Westlands Health Center, but I developed high blood pressure, and that's when I was transferred here to Kenyatta. I underwent cesarean section on 28th of December, was discharged on 31st, but the bill was 20,000 Kenya shillings, which was too high, and I didn't have any money.
Bill ikawa 20,000. Nikakosewa kupata.
I came here on 20th December. I delivered on 4th January, but I couldn't pay the bill and I have no otherwise.
Although it's a sad and painful experience to these patients, who've come to be known as long-stay patients, both public and private hospitals argue that they cannot afford waivers every so often because it puts a strain on the facilities, leaving some of them in a dilapidated state. And in a country where half the population is considered to be living below the poverty line, saving for healthcare does not come as a priority to many.
We don't want to deny Kenyans treatment. On the other hand, we cannot be able to treat free because you will not be able to survive tomorrow if we just allow patients to go.
Be totally upfront with what your charges are, because one of the problems is that patients come in expecting that the only thing they're paying is the bed charges. Now you need to explain to them that in addition to the bed charges, there'll be the doctor's charges, there'll be the drug charges, there'll be the lab charges. So you need to give them a good estimate. At the point at which they're coming in, you need to give them a very good estimate of what you think the bill will be.
Currently, at least 372 patients are detained at the Kenyatta National Hospital, which is the largest referral hospital in the country, due to non-payment of their medical bills.
It has affected because once you have an increased number of patients, you're actually not treating. They are eating, they are using your water, they are occupying beds. It has negatively impacted on availability of bed.
And now if you look at the fact that the hospital has to cater for this person who is there unable to pay the bill. So in a way, if you look at it from an economics point of view, it is a misallocation of resources because the hospitals are not meant to be hotels.
And although the hospital is currently working out a plan to release these patients, they're still very careful not to create the wrong impression.
Now there are those ones who come and they are tutored. So they have what we call wait and see what will happen. There are those ones we treat today, they will tell you I'm unable to pay and we will allow them to go. There are those ones we are able to identify on entry that they will never be able to pay you. So ours is to be able to categorize all those patients, pick them, and then be able to discharge them.
Both public and private health facilities are losing hundreds of millions of shillings in bad debts annually, stemming from failure by patients to pay their medical bills.
Our main measures is, first of all, to try and interest our patients to doing NHIF in our population. And what you'll be doing is that on admission, if you are not a member of NHIF, and since we have the office of NHIF here, we will be now targeting those ones so that they are recruited.
We usually tend to allow them home after we have agreed. They've signed a document and they say that they owe you. So there's a document which actually indicates that yes, there's an amount that is outstanding, and we leave it up to them, yeah, to give us a proposal. When do they think that they'll pay this? If there's any form of security, it makes it even easier. Yeah, is there any logbook, any title, yeah, that they can leave behind that you can store, and this gives them the incentive to come back and pay the bills.
According to the National Economic and Social Council, only 600,000 Kenyans are covered under comprehensive private insurance. The National Social Protection Policy has identified 6.5 million Kenyans as living in abject poverty, and therefore their healthcare needs ought to be provided for through government resources.
Because then of that huge number of people, then one needs to look back and ask themselves, what can you do to make sure that this bottom half of the population is not left out in a sensible medical healthcare arrangement? And this calls for universal plan where every member of the society should belong to a medical plan.
Other suggestions that have been made to pull out of this dilemma include a move towards social health protection that allows the poor and indigent to access limitless healthcare services.
Some of those people who are kept in the hospitals are not necessarily poor. What is their problem is that there is inadequate planning. That you'll find that if they had come to NHIF, the annual contribution for a family is 1,920 per year. Because of that lack of proper planning at the family levels, then you tend to find that people get into catastrophic spending as soon as they fall sick.
The government estimates a 40% out-of-pocket health expenditure. These high medical expenses have forced about 1 million Kenyans to slip below the poverty line annually, while many others die because they cannot afford the necessary healthcare services.
This is a big issue about people being unable to pay for their medical bills in hospitals. As we try to industrialize in line with Vision 2030, and also in view of the ever-increasing population in Kenya, this challenge of people paying for their bills when they go to the hospitals is going to become even a bigger problem. So we need to go back and address fundamental issues that inform the current situation.
The National Hospital Insurance Fund has a membership of only 11 million Kenyans, which represents slightly above a quarter of the population. The scheme offers 3 different types of contracts for hospitals to choose from. There is the comprehensive cover that caters for the whole bill, Contract B where NHIF caters for up to 90% of the bill while the patient caters for the rest, and Contract C where NHIF pays a fixed daily rate to the hospitals.
The bigger problem, unfortunately, is in the around 50% who are the poor people, because the statistics indicate that about 46% of the Kenyan population is in that poor category. Now that is where the problem is. And those are the ones who are more likely to be unable to pay for their bills.
Although Kenya is among the African countries considered by the World Health Organization to be making good progress towards providing universal healthcare, healthcare financing has been under consideration for the last 10 years.